116, there is no vascularity crossing from the metaphysis to the epiphysis, and above that the growth plate or physis closes and the vascular supply communicates directly to the end of the bone. The sites of infection are where these capillary beds are located, so in the different age groups we see different locations where we might see osteomyelitis establishing itself. There's an acute form which occurs with rapid onset. Here are the characteristics. 2 to 12-year-old is the common age group affected, with males more frequently involved than females. We have a latent period, in which case it's not seen radiographically, 10 days in the extremities and up to 3 weeks in the spine. Plain film, therefore, is negative, but a bone scan, which is far more sensitive, will demonstrate abnormal findings much earlier in the progress of this condition. So we don't wait for the plain film radiographic findings, we go straight to clinical diagnosis and a bone scan if necessary. Staph aureus is the common offending organism. Tibia is a very frequent, possibly the most frequent site of involvement, and we get the characteristic appearances of a moth-eaten bone destruction within the bone. Usually there's some periosteal reaction adjacent to the bone. We're not seeing so much of that here. So this would be referred to as the involucrum, and the cortex is usually broken, and that's why the periosteum becomes irritated. This patient has incidentally got a both bones or a BB fracture, and this is why plate and pin is in place. Here's another acute osteomyelitis in the tibia, again the common location, in which case we can see the moth-eaten pattern of destruction, the periosteal new bone formation, which is somewhat layered in this case, indicating an aggressive process. And it's a younger person here. You can see the growth plates are still visible. The second of the 3 forms of infection is the subacute osteomyelitis, also referred to as a Brodie's abscess. And the key radiographic features here include a geographic lesion within the bone, usually a sclerotic border. Sometimes you can see a drainage sinus tract. A periosteal response is usually absent, and once again a bone scan will demonstrate the hot spot or area of increased osteoblastic activity around the outside of the abscess, but not within it, not within the infective site. This radiographic appearance is somewhat almost identical, in fact, to certain examples of osteoid osteoma or the larger osteoblastoma, so we need to consider osteoid osteoma as a differential when viewing an image of a Brodie's abscess. The third form is chronic osteomyelitis, so it's unresolved osteomyelitis, again most frequently seen in the tibia, and we have a range of appearances: sclerosis, lytic changes, thickening and thinning of the cortex, that indicate that the process has been there for a long time. If the infective organism gains access to a joint, it's referred to as septic arthritis, and there is rapid and significant destruction of the joint, relatively even in individuals under the age of 30, and usually it's isolated into one location. Hip and knee joints are the most common locations for septic arthritis, and as with all examples of infection, in this case actually fat fold displacement, if the process remains within the joint, yes, but with other examples which occur in the bone, so in osteomyelitis, particularly acute osteomyelitis, the fascial planes or fat folds are actually blurred or obliterated, and this is a point of distinction between infection and tumours. Waldenstrom's effusion, increased width of the joint space. Subsequently, it will destroy the joint and narrow it, and the moth-eaten pattern of destruction, as we've seen before. Here's an example in the young boy's hip, and we can see the changes in the reading right hip area here. Joint space narrowing once it's established, subsequent acetabular and usually femoral head epiphysis destruction as well. In the spine, we typically see loss of the disc space, and typical of osteomyelitis involving a joint is bone, joint, bone involvement. So we've got reactive sclerosis of the adjacent bone, moth-eaten destruction of affected areas. The end plate is disrupted and the joint space is decreased. Classic for a septic infection, which may be bacterial or tuberculosis in origin or cause. Tuberculous osteomyelitis is the non-pyogenic form, and we can read about it here. Notice that it's also referred to as Pott's disease when it occurs in the spine. And here we're seeing anterior end plate involvement, loss of disc height, end plate is destroyed, there's vertebral body collapse, and they may subsequently develop Pott's paraplegia as a result. TB can also be a form of arthritis, in which case the infection gains access to the joint space, usually again monoarticular, older people, and joint effusion and subsequently erosion, destruction and fibrous ankylosis as an endpoint. Here's TB in the spine. It's almost identical to what we saw with the pyogenic form of spinal discitis. Moving to the category of trauma. Here's a patient who's got a lateral cervical radiograph indicating increased atlantoadenal interspace, so in an adult above 5 millimeters, and in a child above 3 millimeters would be an abnormal finding. The posterior arch fracture, the result of a hyperextension injury, jamming the occiput against the posterior arch of C1 against the posterior arch of C2. No displacement is possible in a bone such as this unless there are two fracture locations, because the atlas is effectively a bony ring, and in this case there is no displacement, but if there were, we would be absolutely sure that there are at least two fracture locations. If only a single part of a bony ring is fractured, then there can be no displacement. This case of Jefferson's fracture of C1 demonstrates this phenomenon, in which case we have lateral displacement of the lateral mass over C2 on the reading right as well as on the reading left. So there is displacement, and we can very accurately presume that this patient has at least two fractures in their bony ring at C1. Odontoid process fractures occur in three typical locations. Mostly we're going to see the type 2 or type 3 fracture, and this diagram demonstrates their various locations. Still at C2, but this time the pedicle of C2. This is the hangman's fracture. Three examples of a pedicle fracture or a hangman's fracture. Axial compressive force, perhaps in this case with a bit of flexion, has produced a burst fracture, and literally the vertebral body affected bursts apart, producing multiple fragments. Here's a facet dislocation. If we follow down from C2, 3, 4, 5, 5 on 6, you can see that the facet joints have dislocated, and this is a result of a hyperflexion injury. Clay shoveler's fracture is a spinous process fracture at the cervicothoracic junction, and this is the result of a hyperflexion injury in which the spinous process tips are pulled away from the rest of the spinous process. An axial compressive force exerted through the thoracic spine can produce these vertebral body compression fractures, and we're looking to establish the location of these decreased vertebral body heights. Usually the posterior body height is maintained until the very last moment, or the last force, and the loss of posterior body height is a sign that we use to query whether there's underlying pathology. In the absence of the loss of the posterior body height, there can of course still be underlying pathology, but we're definitely going to need to chase it if the posterior body height is decreased, as some of these appear to be. Here's a hyperflexion injury again, compression, crush, burst, combination fracture here, also some significant offset, possibly associated with spinal cord injury. Here's an older patient, atherosclerotic plaquing of the abdominal aorta, significantly decreased bone density, multiple compression fractures, especially this one at the top here. suggesting perhaps this one at least suggesting underlying pathology. So